So now we come to neuromuscular fatigue, and it's my pleasure to have the female part of our presidency here for the WM24 is Stanislav Wahonka. So he's a very good friend since many, many years, and I'm very glad that you have time to go in for neuromuscular fatigue.
Thank you for a kind invitation, and thank you for inviting me for this course. Neuromuscular fatigue is a very large topic, and therefore I decided to restrict it for a smaller part, and I decided to speak about neuromuscular fatigue in neuromuscular junction disorders, and therefore to move your attention from the thousand and thousand genes which we have heard today to autoimmune disorders. Yeah, this is my disclosure. And this sketch is very, very simple about which diseases we can speak, presynaptic and postsynaptic. The most frequent neuromuscular disorders is postsynaptic type of neuromuscular lesion disorder is myasthenia gravis, but the presynaptic one is a real rare disorder. And on the other hand, we have a large group of genetic disorders called congenital myasthenic syndromes. But in fact, because neuromuscular junction is the last critical point, last strait on the motor pathway, is also the target for many toxins, like for example botulinum toxin, which blocks the calcium-induced exocytosis and physically destroys the neuromuscular junction. It's not pharmacological blockade, it's a real destruction, and the restitution is due to collateral sprouting or different or other different drugs like peripheral miralaxans, curare, or cholinesterase inhibitors, reversible, which are the very known drugs, cholinesterase inhibitors, which we use for treatment of myasthenia gravis, but also the irreversible inhibitors of cholinesterase, organophosphates, which are used in agriculture, or unfortunately as infamous chemical weapons like Novichok, for example, or a lot of arthropod or snake venoms. If you look at this sketch of neuromuscular junction, if the electrical impulse reaches the terminal button, opens the voltage-gated calcium channels, and calcium starts the calcium influx of to the end of the nerve, and start the exocytosis of vesicles with quanta of acetylcholine to the synaptic cleft, and of course the acetylcholine is binded to the acetylcholine receptors, to the both alpha subunits, and the ionophores are open. Start the changing of the ionic changing on the membrane, and then subsequent electrical impulse. Then the cholinesterase is acetylcholine is degraded by cholinesterase. It's very primitively explain this process. But what is important, we have two important compartments, so-called primary immediately available store with approximately 1,000 quanta, which is just beneath the presynaptic nerve terminal membrane, and the secondary mobilization store, which is 10 times greater. And this secondary mobilization store can resupply the primary store after 1 or 2 seconds. It's very important physiological principle for explanation of many electrophysiological examination. So move to the first case. It's of course not my patient. It's a very famous painting by Gustav Klimt, painted in 1901, and is called Judith with the Head of Holofernes. Traditionally, is is described as the young, pretty woman with sensual look, something like femme fatale. But what can we see as neuromuscular specialists? What gestalt can we about these pictures say? Ptosis, of course, and asymmetric ptosis. What's more? Mild contraction of frontalis muscle, which compensates the ptosis, and also mildly reclined head, which also compensates ptosis. And what this gilded choker, which was the typical part of women dress during Art Nouveau epoch, the collar, which prevents the head drop of the patients with myasthenia gravis. Okay, what diagnosis can we assume in this case? What diagnosis? Myasthenia gravis, of course, but it's only my speculation because the model for this painting was Adele Bloch-Bauer, the friend and muse of Gustav Klimt, but we have no relevant information about myasthenic symptoms in this woman. We only know she was frequently ill the whole life. She was tired, and she had 2 miscarriages. One child died unfortunately 2 days after delivery, and she died in 43 years on meningitis. That's it. We have no reliable information about real myasthenic symptoms. It's only my speculation. So, myasthenia gravis is an antibody-mediated autoimmune disease of neuromuscular transmission. Autobodies are directed against the acetylcholine receptor or other components of the postsynaptic portion of the neuromuscular junction. These antibodies against acetylcholine receptors we can find in 80 to 90% of all cases. These antibodies are IgG1 and IgG3 against the alpha subunit of the acetylcholine receptor, and it's important information because IgG1 and IgG3 activates complement, and it has some consequences for modern therapies. We speak about a seropositive myasthenia, which is pathogenetically associated with thymic diseases. Also Judith has the revealed chest ready for thymectomy, of course. Thymoma occurs in about 10% of all patients. In majority of cases is benign. Approximately half of seronegative patients have antibodies against the muscle-specific tyrosine kinase, anti-MuSK antibodies, which are IgG4. It's also important information. There are double seronegative cases of myasthenia gravis, and in these cases we can find sometimes lipoprotein-related protein 4, LRP4 antibodies, which these antibodies we can find in approximately 1% of all cases of generalized myasthenia gravis. It's a very rare condition, or antibodies against agrin. Myasthenia gravis is a disease with increased prevalence. We know it from the, for example, study from Slovakia. In Slovakia, they have the very large timeline of patients with myasthenia, and the incidence and prevalence steadily increase. And the contemporary from the German data or American data, we know that the prevalence is more than 30 cases per 100,000 inhabitants. So, myasthenia gravis is also a disease with very deep impact of quality of life. As you can see from the screenshot from the one European paper, and also have the deep impact of the mortality. From the German study from the last year, and you can see that the mortality of patients with myasthenia gravis is 5 times greater than in normal population, despite of the fact of the progress of the modern therapies and the care of patients and so on. Now to the real clinical picture of patients. The fluctuating muscle weakness that varies in severity, worsens with physical activity, and improves with rest is a typical core symptom of sign and symptom of myasthenia. Fluctuation of symptoms are most prominent at the end of the day or work shift. In many patients, is portrayed as fatigue. Only one symptom is typical morning after wake up, diplopia. Why? Due to frequent rapid eye movements, REM movements during morning sleep, and therefore the ocular muscles are tired after wake up morning. Generally, extraocular muscle weakness, diplopia, ptosis, or both are the most frequent symptoms, and the ptosis is typically asymmetric and fluctuating. It's different to the, for example, muscle diseases when the diplopia, when the ptosis is fixed. And also diplopia is variable during the day. The 85% of patients will have starts with this disease odyssey with these symptoms. And then the symptoms can progress to the pulbar muscle and to the upper and lower limb muscle. It's a craniocaudal, deterioration. Here you can see two patients with asymmetric ptosis. And if you open the ptotic eye, passively open the ptotic eye, on the other eye, you can see that the ptosis becomes more pronounced. This phenomenon is called Gorelick sign. It's typical for asymmetric ptosis in patients with myasthenia. Of course, you can see here also the patient with asymmetric ptosis. If the patient look ahead, there is no asymmetry of the eyes, and if the patient look up, you can see the obviously the asymmetry of eyeballs, the abduction of the left eye, and this patient, of course, must have diplopia. But in many cases, the eyeballs are parallel, and despite this fact, the patient refers diplopia because the even small difference in the position of eyeballs produces diplopia. This is only illustration how looks the symmetric ptosis in different neuromuscular disorders. The first patient you really know, it's the lady on the left, is typically is myotonic dystrophy type 1. The other patients are more complicated. It's a polymerase G mutation, and the third lady on video is Kearns-Sayre syndrome. So, after the ocular symptoms, the most frequent are bulbar and facial syndrome, and then the disease progresses to the cervical and limb, and finally to the respiratory muscles. The isolated bulbar muscle weakness is initial presentation only in 15% of cases, and the but in oculobulbar complex is the most frequent manifestation of myasthenia gravis, typically difficult chewing or frequent choking, dysphagia, orsenes, dysarthria, difficult swallowing, biting hard meal, nasal speech, etc. In case of weakness of facial muscles, you can observe the very tired look and expressionless face. In case of neck muscle, of course, drop head syndrome. Limb muscles are also frequently affected, typically proximally and more upper limbs than lower limbs. Typically, patients is not able to shave, to comb, is not able to put things in the upper compartment or drawer in the kitchen and etc. The problems with lower limbs are, of course, problems with climbing the stairs, of course, or getting up from the low chair. A lot of patients say to you, sorry, I prefer remain remain standing because they is not able to get up from the low chair. And the most threatened complication is the involvement of intercostal muscles and diaphragma, which leads to the myasthenic crisis. You can see here the dysarthria, and you can hear the dysarthria at the tree. And also you can see the very tired look, and also short breaths also. Okay, you can stop it. The next slide, which demonstrates the neck muscle weakness, is also not my patients. It's former Soviet Union Communist Party leader Mikhail Sergeyevich Gorbachev, but this picture demonstrates is nice demonstration how the patient helps to prop his chin by hands. Mikhail Gorbachev, of course, had no myasthenia gravis. It's a famous portrait by Canadian portrait photographer Joshua Karsh. There are a lot of pitfalls in diagnostics of myasthenia, and we speak about that myasthenia is a great pretender. Because, for example, I had a patient who was not able to sing high notes, and this lady was a member of a church choir, and it was for her very unpleasant. And at 3 months, they was visiting different doctors, and then unfortunately, started the classical myasthenic symptoms, and she was diagnosed and treated. In many cases, it's my observation, a small range of diplopia is sometimes by patients presented as blurred vision. Patients seek an ophthalmologist and change glasses, or very slight weakness of the neck muscles is sometimes perceived as a feeling of tension in the cervical spine, and the patient frequently see chiropractors or take analgesics. Of course, dysphagia is perceived as an obstruction in the throat, and the patients are repeatedly examined by ENT specialist. The myasthenia we can classify from the different views as ocular or generalized, but the generalized form frequently begins with the ocular symptoms, and we have so-called 2 years rule. It means if the myasthenia remains restricted to the ocular muscles for 2 years, the risk of generalization is much more lower, approximately 15%. Juvenile versus late form, of course, or thymoma-associated myasthenia, or we can classify myasthenia according to antibodies because anti-MuSK myasthenia has a slightly different clinical picture, or of course seronegative myasthenia. It's a very known Myasthenia Gravis Foundation America clinical classification of patients with myasthenia. Class 1 is only ocular symptom, and class 5 are patients who are intubated with or without mechanical ventilation. The most frequent cohort are patients with class 2B. It means oculobulbar symptoms, and bulbar symptoms are more pronounced than the limb symptoms. About the workup of patients with myasthenia gravis, of course, antibodies are the essential test for these diagnostics, but traditionally electrophysiological tests are used, especially are very useful in the case of seronegative myasthenia, low-frequency repetitive nerve stimulation, or single fiber EMG. Pharmacological tests we are using ultra short-acting cholinesterase inhibitors are not in Europe used, but what is useful is the diagnostic test with anticholinesterase inhibitors of cholinesterase, taking, for example, orally or intramuscularly. iSpec test you have already seen in the lecture of Anna Kostera, but in myasthenia we expect the opposite result, the improvement of the ptosis after cooling of the eye. Imaging is of course necessary part of the workup of patients with myasthenia, but it's not the diagnostic test for myasthenia. It's diagnostic test for exclusion of thymoma, and also other laboratory tests are recommended because myasthenia is frequently connected with other autoimmune disorders and also the thyroid gland disorders. Repetitive nerve stimulation is very important examination which has very high specificity but not so high sensitivity. The cutoff value for decremental response to the force answer is 10%, but some authors say that even a decrement of 5% may be considered abnormal, but I would underline what is in the parentheses 2 times, if artifacts demonstrably are not responsible for the changes. It's extremely important, and also it's important not to see only the pattern between first and fourth, the difference between first and fourth or fifth CMAP, but to see the whole shape of the answer, because for myasthenia gravis is typical mild rebound after the fifth answer during repetitive nerve stimulation. It's due to, of course, due to the principle that after 1 or 2 seconds, the calcium ions can resupply the primary compartment and increase the number of acetylcholine molecules for the synaptic cleft. But what is very important to see this mild rebound phenomenon. It's essential for the correct diagnosis that the decremental response is really myasthenic, not only the difference between first and fourth CMAP. Single fiber EMG is the most sensitive test, but is not so specific. The abnormal jitter we can find in at least one muscle in 99% of patients with generalized myasthenia gravis, in 97% of those with ocular myasthenia gravis. It's extremely sensitive test, but not so specific. And On the other hand, normal jitter in the muscle with weakness, the myasthenia gravis is practically excluded. In other words, negative predicted value is very strong. What you can see is a stimulated type of single fiber examination. It's extramuscular axonal microstimulation. We stimulate with subdermal hypodermic needle a small branch of facial muscle and record from the orbicularis part of orbicular part of oculorbicularis muscle. The great advantage of this examination in comparison to the spontaneous single fiber that it doesn't need the active cooperation of patient. Of course, the patient must not move the hand or blink or forcefully close the eyes, but we don't need any active cooperation. The stimulation frequency is constantly set up, and therefore the jitter is not influenced by frequency or by firing rate, as in case of spontaneous single fiber electromyography, and the examination is very quick and takes 10 to 15 minutes to collect 20 end plates. So we use different scales for examination of myasthenia gravis. ADL, there's the patient-oriented reported outcome measure for some interval, but the QMG scale is a scale which is instant scale, is instrumentally. We need the instruments for this examination because spirometry and dynamometry, and it's instant. Now we examine the patient with one moment, but because the myasthenia fluctuates significantly, after 2 hours the situation could be different, and therefore if we want to use repeatedly QMG, we should use it during the same time of the day. The patient must be without anticholinergics, and therefore it's quite complicated in real clinical life. MGC is the myasthenia gravis composite is a combination of those scales without any instruments, and QOL-15 is the scale which is quality of life of patients with myasthenia. These four scales are the most frequently used. There are many other scales. Very briefly about therapy. Therapy is based on, of course, immunosuppressive therapy, steroids, in acute stage, of course, immunoglobulins or plasma exchange. The very quick relief is by the using of cholinesterase inhibitors. But what is important is the time to onset of action of all immunosuppressant drugs and thymectomy. And I read very nice note in one paper, a very nice notice that the therapy of myasthenia is not a sprint, it's a marathon. It takes very long time to start the effect of the therapy. So, away from the myasthenia gravis, and the second case is a real case. Woman referred as double seronegative myasthenia gravis, 6 months proximal weakness of upper and lower limbs, 1 episode of worse swallowing, leaking foods through the nose. In the regional hospital, she had abnormal repetitive nerve stimulation, chest CT was normal, and she was double seronegative. And they tried to use Medrol and Sulmedrol without effect, and inhibitors of cholinesterase with very mild effect. She was referred to our center. What we learned later, she is suffering from dry mouth, orthostatic hypotension, especially after meal, and she had absent deep tendon reflexes. Conduction study and needle EMG was generally normal, only generally low amplitude of CMAPs. Because she had the proximal muscle weakness, we performed also CK and myoglobin examination, which was normal. And we performed single fiber EMG, clearly abnormal, and then we repeated repeated nerve stimulation, and what we see is the clear decremental response. Then we started the isometric contraction. I try to move it. For 20 seconds, isometric contraction, but you can see that the decremental response has no rebound, as in case of myasthenia, no rebound. Then we started isometric contraction, and you hear the muscle activity. Yeah, and the diagnosis is done. After isometric contraction, you can see the increase of the initial CMAP amplitude. In the next muscle is the same situation. Also, clear decremental response. Okay. So the initial amplitude, the first run was 0.9, the second after isometric contraction, 3.5. So there is a summary of repetitive stimulation of 4 pulse nerves. In all nerves, we can see decremental response and clear increase of CMAP after exercise. We examined anti-voltage-gated calcium channels, highly positive, and diagnosis is fixed. It's Lambert-Eaton myasthenic syndrome. Typical for decrement of Lambert-Eaton myasthenic syndrome is that there is no rebound as in myasthenia gravis because there is no possibility to resupply the acetylcholine from the secondary compartment to the primary compartment. Sorry, I didn't estimate the time. Thank you very much for your attention. Sorry, I didn't estimate the time.
All fine. Because we are a bit late. So
I let it for the next presentation.
Yes, so questions related to neuromuscular fatigue. Is there anything who wants to add something on Lambert-Eaton? But also, Stan will stay with us for the dinner as well, so there's also time for this. Thank you.
Thank you.